Hey everyone, and welcome back. I'm going to divide Unit 4 into two sections. The first half, we're just going to talk about therapeutic groups, and then I'll have a second group for suicide and non-suicidal injury. So when we talk about group therapy, this has been going on for quite some time, informally. We really started seeing formal groups come after World War II. And the whole purpose of having a therapeutic group, we are meeting for personal development and psychotherapeutic growth. There is a guy named Yalom. He has this huge, massive book on group therapy. We're in like our multiple different editions. And he basically said, hey, look, there's a reason why people go to group. He called them the curative factors, the things we get out of group, which one of the big ones being universality. Other people have experienced the same thing as I, so I am not alone in my problems and my struggles. And then altruism is another one. I help other people, so I grow, and that in turn improves my self-worth. Altruism is actually, if we'll talk about AA a little bit in this lecture. We tend to see altruism in that 12th step of AA. I'm going to go and help other people as AA has helped me. We have a whole bunch of other curative factors that are in your textbook: interpersonal learning, recapitulation of the primary family group, catharsis, just kind of getting it out there. So there are a bunch more, but universality and altruism are our two big ones. So group leaders in these therapeutic groups, there is usually someone who is leading it, and that person also serves the role model to mimic and kind of show our patients these appropriate behaviors. So when it comes to group therapy, the first thing we have to do is develop our group. Very, very similar to the phases of that nurse-patient relationship, we have phases of group development. So in the first stage, we're literally just planning. We're coming up with what our group is going to be. The second stage is orientation, and this is that first group meeting. We talk about the rules of our group. Right? We're not going to talk about members non-group. We're going to be polite. We're going to be respectful. We're going to let everyone have a chance to share. We're going to talk about why we are having group, and then we're going to ask everyone to go around and introduce themselves. In the working phase, just like in that working phase of the nurse-patient relationship, we are doing all of the meat and potatoes. If we have a group who is meeting routinely, right, the same group of people every week, we tend to see that storming, norming, performing. The first group, we might have some disagreements, and then as the same group keeps working, they start doing better. The last group, just like that termination phase, we say goodbye. We thank everyone for their insight. Maybe we talk about what they've learned in group. Now, when it comes to our group participants, we have a few things that we see in how our patients socialize. We have task roles, and this is kind of someone who tends to, just kind of how they are, keep the group focused. They're going to keep everyone a topic, and it's just as a group member, they will be doing this kind of on their own. Our maintenance roles are more like you're nice people who try to make everyone be friends and get them talking, and they really want cohesion in the group. Our individual roles are the ones we're going to focus on throughout this kind of discussion, because they are the ones who tend to cause problems. You want task roles, you want maintenance roles, because those are the group members who are helping the group grow as a whole. Our individual roles want nothing to do with the group. It is only going to be about their personal desires. And we'll talk about a few examples coming up. When it comes to group leadership, we have a few different types of leaders. Our autocratic leader very much wants control. These tend to be more of what we see inpatient, where you're coming in, you're leading, fixed limit. I'm kind of going to do most of the talking as the leader. Democratic is more our true psychotherapy, so our therapist-led groups where we are empowering other people and we want everyone to talk. Laissez-faire, we're honestly going to think like art therapy. We are going to be like, hey, let's all go paint pictures. And we're just going to kind of let everyone figure it out on their own, very loose flowing boundaries. We will see communication in group therapy. We talked about therapeutic and non-therapeutic communication techniques. That does exist in group therapy. The difference is now we are applying it to a group. So active listening. As the group leader, we should actively be listening to all members of our group. Sometimes you might have to ask questions. Can anyone tell me about a time, right? If I'm teaching a group on sleep hygiene, can anyone tell me something that they do that helps them sleep? Or Can anyone tell me anything that they do that hinders sleep to try to get the group talking? Clarification, just like before we had a bunch of clarification techniques. I heard you say this. Can you explain what you meant when you said it? Reflection. Joe, I see when you're talking about this, you are, playing with your fingers, rubbing your head. Are you anxious? And we're reflecting the patient's action back with an emotion to try to help the patient connect their feelings and emotions with what they're discussing. And then support. As people are sharing often in groups, especially if we're doing like more of a feelings, talking about things that are going on, trauma, it can be hard for these patients. If someone shares something and they're very upset, we can thank them. Mary, I thank you so much for sharing about that. Can anyone else relate to Mary? Or can anyone else share or talk about a time when they faced a similar situation with a loved one? And help get the rest of the group to support the patient, along with us supporting the patient. So when we look at our kind of individual roles that we see for the patients, the ones we do not want, we sometimes have a monopolizing group member. This is someone who is going to talk and talk and talk and talk, and they are not going to let anyone else share. They tend to always make it about them. So this can be hard because we want everyone in group to have a chance. If one person is always talking, maybe your more anxious members, your more quiet members, they're not going to speak up. We should always address the entire group. That's part of those group ground rules. Everyone needs a chance to share. So hopefully we have already addressed this, and we could maybe just remind the group, hey, we want everyone to have a chance to share, so let's kind of limit our thoughts. We might have to actively ask this person, though, to limit what they say. I appreciate so much how much you're sharing today, but I'd love to give other people a chance to talk. Can we limit your comments to just one or two for today? Sometimes we may have to discuss it after the fact individually with this patient, depending on how the patient is and how it's going. But often asking them to limit their sharing is what is going to be needed. Our demoralizing group member. This is someone who's rude, they don't have the empathy, they're going to challenge other people, they're going to put it down, it's going to be everyone else's fault. Oftentimes when this has happened, the anger is coming from somewhere. So we need to have an open mind. We need to not take it personally, but we also don't want anyone else to not want to share, right? Because in a group, it's about our entire group, not just one patient. So kind of figuring out what is happening. We may have to talk to this patient after group 2 to see like, hey, look, what is going on? Maybe they're tired, they had a fight with a spouse. Maybe the topic just brought up some bad memories. Or it could just be that they're not very nice. It could be we just do have someone, maybe because of their psychosis, whatever is going on, that they are just really struggling. And that again is where setting those ground rules comes in helpful, because we can remind the group of our ground rules. Sometimes we can have a silent group member. This is someone who's not sharing. We can't assume that they're not paying attention. They may be more anxious, may have that social anxiety. We can see it with some of our personality disorders. Maybe they have a slower cognitive function, or it just takes them longer to process. Often what we can do with this patient is, for the entire group, give them a chance to write it down. Here's a little piece of paper and a pencil. I want y'all to each take, 5-10 minutes to think through your thoughts and feelings. And then we will come back and share your response. This way that patient has that longer time to consider their answers before they have to share. So why do we do group therapy? Well, as nurses, we're primarily going to be doing psychoeducational groups. We want to teach our patients something. And in that psychoeducational group, our patient will demonstrate knowledge. So very simply, we still want goals in groups. If I'm doing a group on sleep hygiene, right, how to sleep better, my goal for that group, my expected outcome would be the patient, demonstrates increased knowledge related to sleep hygiene, and the patient can express 2 new strategies they will use to work with sleep. Therapy groups, nurses can do some. We can do some very basic. Usually we stick with more of the education, and in those therapy groups we want behavioral change. We want to talk about like reducing symptoms, getting the patient to identify and think about what is going on. Usually inpatient especially, we tend to see therapy groups being run by therapists or advanced practice providers, with educational groups being the greater focus of our kind of frontline nurses. And that was super fast because we were done with group therapy already. If y'all have any questions about it, please let me know.